you can access this at a later time. But we are very happy to have Dr. Kiran here from Sargent College for Health and Rehabilitation Sciences at Boston University. She's professor in the Department of Speech and Hearing Sciences over there and associate dean for research. She's also, her work is mainly focused on brain injury and aphasia. And she's here to share with us her expertise and work on aphasia rehabilitation. I would like to thank the task force for getting Dr. Kiran here with us as a speaker. And Michelle, I'm not sure if you wanted to have a couple of seconds to share anything from the aphasia task force.
Sure, yeah. So our aphasia task force is led by myself, Michelle Armour, and Christina Del Toro. We are co-chairs together, and we lead the task force through the stroke ISIG of ACRM. All are welcome. It's recommended we have to have you be an ACRM member to be a member of the task force, but we have members from across the country, and we work on different projects together and have a conference call every other month to kind of touch base, and you can be as involved or as you want to be. So if you're busy, don't have time, certain times in the year, you don't have to volunteer, but if you want to get more involved, you're welcome to volunteer for whatever you like. We work on presentations at the annual conference together, and most currently we're working on 2 publications through the ACRM information education pages. So just a couple examples of some of our projects. But the more the merrier. So if you are interested, I'll put my email in the chat box here, and you guys can reach out to me, and Christina and I can get you more information.
Okay, so without further ado, we give the floor to Dr. Kiran. Thanks again.
Okay, thank you. I'm assuming everybody can hear me. I'll keep the chat box open for a little bit just in case people are having issues with audio and somebody can look at it. So I've only done this once before. It's completely web-based, and it's a little bit strange because I have no feedback of what the audience is thinking as I'm going through the talk. And I was told when I asked about how to prepare for this presentation, I was told to plan for about 30-35 minutes and then engage a discussion. And so that's what I'm going to do today, as I'm going to try to engage a discussion here. It'll be fun to have it over web. But thank you to the organizers, especially Michelle and Cecile and Christina for asking me to come speak and being patient with all the different scheduling. So I do have to disclose a few things first. I do have a significant financial interest in the Learning Corp. I'm a scientific consultant, and I was the co-founder before, and I will mention it today, so I do want you to know about that. And I've been fortunate to have grant funding almost continuously in my career, including some foundation funding like the Coulter Foundation and Asha Foundation. Okay, so what I thought I'll do today is give you the summary of my talk up front and tell you what I'm trying to convey, so that as I'm going through my talk and making the evidence for my somewhat provocative claims, you're thinking about ways to engage the discussion and ask me questions along the way. So I'm going to tell you my story for the take-home message first, and then essentially walk you through the details afterwards. I think this is probably a well-known claim. I think people agree with this, that intensity is an important aspect of neuroplasticity, especially after a stroke or a brain injury. So I don't think we'll disagree too much there. The second point I'd like to make, and I think, again, most people who are working in this field know this, that intensity in aphasia therapy is an important variable. It's something that we have to consider when we're doing clinical work with our patients. I want to make the waters a bit muddy by saying that even though we know intensity in aphasia therapy is an important factor and an important thing for us to consider, it's really complicated because intensity has been defined and measured differently across studies. And so that it hasn't been an easy road to understand how intensity drives treatment outcomes in aphasia rehabilitation. So that's my third point. I'll spend some time trying to explain why this has been sort of complicated. And then my fourth point is I think the most contentious / provocative point is I think current aphasia treatment studies and clinical practice do not provide intensive aphasia therapy by any long shot. And this is where the problem is independent of the way we discuss intensity, we're not giving intensive aphasia therapy. So that's a problem. We have to find ways to solve it. And I'm going to only suggest one option. There are many options that given changes in technology that are happening, this is one way to provide the kind of intensive aphasia therapy that the patients may need. So for the rest of my presentation, which I hope will last about 35 minutes, I'm going to try to give you evidence for each of these points that I'm making. Okay, so the first point. The first point is that intensity is an important aspect of neuroplasticity.
And if you want, I'll push her. Apparently you do.
Could somebody mute themselves? Because I can hear some side conversation.
I'm sorry, Dr. Kiran. If you are on the phone, could you please keep your phone on mute or mute your microphone on the computer? Thank you.
Great. Okay, thanks. So this is, I think, well established knowledge for most people here, that the brain has this amazing capacity to be adaptive, the central nervous system does, and this is work from Steve Kramer back in 2011. The idea that the brain's capacity to form new circuits and learn new behaviors or skills
maybe so, I'm texting
him. At the same time, when somebody has a brain injury or has a stroke, the brain has a similar capacity to form new connections or recover lost skills and behaviors. So the brain is endowed with this ability to be plastic, and there is a way to change it. And that's really what we're all going after when we do our rehabilitation with stroke patients. Another seminal paper that you should be aware of is a paper by Jeff Klein and Teresa Jones in 2008. It's in JSLHR. And they're physiologists and actually cognitive science researchers who've done a lot of work in animal models of plasticity. And this paper that's in JSLHR tries to describe the principles of neuroplasticity that they've learned from animal models of recovery that can be applied to language rehabilitation in specific, and I would say probably rehabilitation in general. And the 10 principles that they identify in this paper are you either use it, the brain needs to practice, or you lose it. The brain needs to use it, and if it uses it often enough, it would improve it. There's a specificity to the kind of training that the brain needs. You can't just expect it to absorb from the environment. The training needs to be targeted. By the same token, the training needs to be salient in order for it to change and become more plastic. Ideally, neuroplasticity involves a component of transference where you're training one behavior. As long as you train it sufficiently, you will get transference to related behaviors. But there's also a possibility of interference where if you train one behavior and you train another behavior too close to it, they might interfere with each other. And there are some great examples of this in the work that they present with animal models. Some more important concepts of neuroplasticity include the time of the training. So when you train, provide the treatment is critical, and the age of the organism, or in our case humans, the age at which this intervention or this retraining or this neuroplasticity is being harnessed is critical. So obviously, the younger you are, the more neuroplasticity you could show. And then another important concept, which sort of relates to what we're talking about today is that the brain cannot necessarily change until it gets sufficient repetition of input. So a single exposure of anything is not going to make the brain plastic and change over time. And by the same token, intensity is also required to be ordered in order to be able to facilitate that sort of change. So you need lots of repetitions and intense treatment. And that's really what we're trying to focus on here. In their examples, they provide from animal studies, the most compelling evidence, I think, is that they have found that when rats practice about 400 reaches per day on a skilled reaching task, they start to see changes in the synaptic number in the motor cortex. So if you're not familiar with this work, it's really interesting because they train the rats to do a certain behavior, and then they look at the actual synaptic density in the motor cortex, and they see these clear changes. There's increased synaptic density, new synapses are forming in these rats' brains. By the same token, when rats practice only 60 reaches per day, they don't see the same level of synaptic increases. So there's a clear correlation with how much practice the rats get and how much the brain is actually changing over time. It's much harder to do the similar kind of work in adults, and especially in terms of language. But there's a fantastic set of papers that came out in 2011 in the Journal of Communication Disorders that essentially was taking off this point that Clyman-Jones present in the context of aphasia, but in general of just plasticity after damage and without damage in the human brain. There are some really great papers here. I would encourage everybody to take a look at it. The one that's most relevant to aphasia is the paper by Julius Fredrickson. But they're all sort of saying the same thing, is that the brain is plastic, and they provide various instances of how Clyman-Jones principles might play out in this context. Okay, so long story to summarize there, but there is fairly enough evidence out there that intensity is an important aspect of neuroplasticity, and it is something that we can at least have been able to measure in animals, and we could probably document in humans as well. The next point I want to make is that if intensity in aphasia therapy is an important variable. But before I say that, I think I need to put it in context, in a broader context. So there are lots of factors that are going to affect whether a patient with aphasia can recover after a stroke, and how much improvement they're going to show. There are clearly factors such as the patient's age, the lesion location, the lesion size and volume, the months post-stroke, the education that the patient has, and the severity of impairment that will influence the outcomes. These are all patient factors. There's nothing that, all of these are factors that the patient brings to the table, and each person's different. Then there's a whole host of treatment factors, the kind of training that might also influence treatment outcomes. And this is where intensity and dosage fall in. These are actually things that are manipulable across different patients, even though they may bring this other set of factors about themselves into this equation. So intensity and amount of therapy, the optimal dosage of that treatment, the type of treatment that they're getting, and where they're getting that treatment also influence the therapy outcomes ultimately. So with that in context, looking at what has been done or what has been looked at in the context of intensity in aphasia, this is obviously not a new topic in aphasia rehabilitation, and there have been several studies that have tried to bring together evidence across or meta-analyses of studies. And the first one, the most well-known one, is by Randy Roby in 1998, where he reviewed a few studies at that point, looking at how much gains patients made in terms of the intensity. And what he found in his meta-analysis was that more intense treatment led to greater change than less intense treatment in those studies. Then there's a paper by Vogel et al. In 2003, and they found significant gains in treatment were observed when the average therapy is about 8.8 hours per week for about 11.2 weeks. But when the average therapy is 2 hours of therapy for 22.9 weeks, no significant gains were observed. But the point here is that they reviewed 10 studies, and these were the interpretations that they made. Cherny et al. In 2008 reviewed another set of, this is another meta-analysis, this is an evidence-based review, and they also found increased treatment intensity related to greater changes in outcome measures. And so actually outcome measures are greater for the studies that show more intense versus less intense treatment. But this review also only looked at 10 studies, and 5 of them were focused on constraint-induced language therapy. And I don't know if you're aware of constraint-induced language therapy. It's sort of the hallmark of doing intense aphasia therapy for a short period of time. And so Cherny's conclusions are not as positive. They're more constrained in that we need to think about the factors that promote this therapy, that promote intensity. There's the latest Cochrane review by Marion Brady in 2016 also looked at this issue of intensity, and they actually looked at 27 studies and about 1,600 patients in their review of the data. So it's a bit broader, and it's probably the most recent review of this literature. And when they looked at functional communication as an outcome measure, they found that it improves when patients receive therapy at a higher intensity. And so the studies that they bucketed in the high intensity were between 4 to 15 hours a week, as opposed to studies that had like 5 hours as a max. When the therapy had high dose, and so the high dose bucket that they looked at were studies that included between 27 hours to 208 hours in total, and over a long period of time, so up to 22 months. Some studies looked at up to 22 months of intervention. So these numbers are fairly large, but this is what seems to be what the studies that have shown these sort of gains have published. There's another study that came out about now a year and a half ago by Katharina Bertenstein and a whole group in Germany, and they looked at the effect of intensive language therapy in individuals with chronic aphasia. They had 2 groups there. They had 150 patients, so that's why I'm talking about this, because it's a new study with a lot of patients. And in their intervention group, the patients received 3 weeks of intensive therapy. In the control group, the patients got 3 weeks of deferred treatment, and then they got 3 weeks of intensive therapy. So they got the same type of therapy, only later. And the type of therapy that the patients got was either individual therapy, group therapy, or self-managed sort of computer-based therapy. But you can see that they were getting a lot of therapy during those 3 weeks of time. What they found in that study was that the intensive therapy group, whether it was, that got the sort of distribution of different types of treatments, did show significantly greater improvements in verbal communication, specific linguistic measures, as well as quality of life. And this is compared to the deferred group, the deferred treatment phase. And these patients also showed maintenance in the follow-up treatment. So this, I think, is probably the most compelling evidence we have yet that shows that speech-language therapy that's provided intensively is beneficial. But one of the criticisms about this study that I've heard is that it was too short. 3 weeks is not enough of treatment, and the gains, while they're significant, they were not like massive gains. So that's one of the issues that we'll come back to later on. And to get to what's actually happening in the real world, if you look at the Asha National Outcomes Measurements data, and this is data from adults in healthcare, outpatient healthcare that was pulled out from 2017's data set, the report shows that so on this graph, what you're seeing is the amount, the functional communication level at discharge, so where they actually were when they were discharged and how many treatment hours they got when they were at discharge. And you can see that so as you move to the right, you're at a higher level of functional communication. So level 7 is more functional communication than level 5. But to get to a patient who is level 7, the therapy requires, the patients had about 13.4 hours of therapy versus somebody who's getting 5.8 hours of therapy in level 5. So you need more treatment hours to get to a higher level of progression as well. And this is the data that's being entered into national outcomes measurement as well. So you'd think that at this point, there's fairly compelling evidence that intensity is good. And there's all these data pointing to the fact that what we should be doing is getting all these patients to get as much intense therapy as often as possible, right? It seems like a slam dunk at this point, right? But it's not. It's not, because the way we measure intensity and the way the studies are defining it are really, really different. So it's been really hard to say, what is that in optimum intensity? What should that intensity be when a patient comes in? Because people just don't agree on what that should be. So just to sort of give you some more examples of why this is quite complicated right now. I did talk about evidence that I just presented, including Erin Godecki's work in the Brady et al. Meta review that says that higher intense therapy results in greater treatment gains than lower intense therapy. And these are the studies that actually compare the intensity directly. However, there are also studies like the Stahl et al. Study in 2017 that also directly compared intense therapy versus less intense therapy and didn't really find the different results to be that different. So there's some, clear studies that show opposite findings of better intensity, better outcomes. And something that's been coming up a lot lately is the rate at which this therapy is delivered. So there's at least 2 studies, and there's some more that I didn't cite here that have been suggesting that you can, if you equate intense therapy to mass practice, you do a lot of practice, really, really bunched up, that mass practice may lead to better acquisition, so they learn the behavior well. But the maintenance of treatment effects is really not coming from this mass practice. It's really coming when the therapy is done non-intensive and spaced over time. So you get better effects when the therapy is done in a mass practice, but you get better maintenance when the therapy is spaced over time. So this is essentially suggesting that maybe you don't want to do all that intense therapy, because in the long run, they may not actually maintain any of those gains. So this is very complicated, right? Because there's no one consensus finding here. The other thing that's really complicated is the way people define intensity. As I'm going to show you, you can talk about therapy as the hours of therapy somebody gets. You can define therapy in terms of the total number of sessions that somebody gets. You can define, if you're talking about patients in the acute care setting versus inpatient rehab versus long-term setting. It's a number of, you can define intensity as the length of stay in the hospital in terms of the length of stay in days. Warren et al. Suggests that we should actually be talking about cumulative interventional intensity. That's something that I agree with, is that you have to sort of really calculate a combination of hours plus items plus frequency plus overall duration, but nobody's really done that yet, but that's one way to look at it. Intensity can also be just described in terms of number of items practiced, is how many repetitions are you getting, and the more repetitions you get, that's more intense. And then more interestingly, it could also be defined as the effort expended during a therapy task. So this is more like the way you get a high intensity workout exercise, where it's not so much how many items you do, it's how much cognitive effort you're putting into that. And the harder the therapy, the more intense it's supposed to be. So that's another way to define intensity. And the problem studies have looked at intensity defined in lots of different ways. Here's just an example of why this gets complicated. On the horizontal dimension, it's looking, I've sort of put studies that have looked at more hours of therapy versus less hours of therapy. And on the y-axis, on the vertical dimension, it's more frequent therapy versus less frequent therapy. So you can have studies that are less total hours and less frequent, like 2 hours a week, and that's all, and you only get 10 hours of therapy. Or you could have a study that's looking at 5 hours a week, and that's 100 hours of therapy. You can even have studies that have looked at 5 hours a week, then they get 300 hours of therapy. So there's a lot. There's at least 2 dimensions to look at it. Actually, there's 3 dimensions to look at it, because this doesn't, the less number of hours and the less frequency could also intersect with less duration. So the overall duration also matters. And so lots of studies have defined these differently. And And another way to understand what I just presented is to actually take this and space it out. So this is just an example, but you could have somebody who comes in who gets a duration of 6 hours of therapy and comes 4 times a week and only gets that for 2 weeks and is going to end up with 48 hours of treatment. You can have somebody who gets 3 hours of therapy who comes 4 times a week, but for 4 weeks and also gets 48 hours of treatment. And then lastly, you could have somebody who only comes once a week, gets 2 hours of sessions per week, but does this for 24 weeks and still gets 48 hours of treatment. So clearly on the top here, we're talking about intense treatment that's sort of bunched together. There's a lot of it, but the duration of that treatment itself is not very long. And then here you've got the more spread out, the spaced treatment where you're getting therapy less frequently, but it's spread out for a much longer period of time. And the problem here is that while this does break down into mass practice versus distributed practice, they're all only getting the same amount of hours, and that's only 48 hours of treatment. I mean, ideally, if you were listening to what I said about the Brady study and these other studies, therapy needs to go on much longer, so you need some sort of interaction of all this. So this is where I think the state of the science is right now. There's a lot of ways to define therapy, and because people don't completely agree on that, what one study calls intense therapy is not what another study calls intense therapy. That might actually be less intense based on a different study's definition, and that does make things complicated. So that was my third point, is that even though it would seem logical to assume that more intense therapy is better, it's actually very hard to implement that because intensity is defined differently across studies and it's measured differently across studies, and there's no benchmark for what's considered high intensity because all of these factors change. But this is really problematic because at the end of the day, we're not doing the kind of intense therapy we need to be doing. And this is quite, so it's quite a bit of a practical problem, but it's also a scientific problem. So here are the stroke guidelines from different organizations. The one on the top is the Stroke Foundation's guidelines this is from Australia, and their recommendation is for stroke survivors with aphasia, intensive aphasia therapy, at least 45 minutes of direct language therapy for 5 days a week, may be used for the first few months after stroke. That's from the Brady study I just talked about. From the Royal College of Physicians, this is from UK. People with stroke should accumulate at least 45 minutes of appropriate therapy every day at a frequency that enables them to meet their rehabilitation goals for as long as they're willing and capable of participating and showing measurable benefit. And then from the American Heart Association, Stroke Association, they're saying they should receive early treatment and monitoring. It's a little less stringent, but they should receive it to optimize recovery. And then what they're saying, the reason they're guarded here is because what they found in their review of the literature is that only 1/3 of treatment subjects receive the prescribed treatment, that is 2 hours a week of 24 weeks. And while they're saying that that's efficacious, they're starting to recognize what I think is the real problem, that the therapy is really not that consistently intensive as it's supposed to be. At least it's not as intensive as a recommendation. The guidelines are suggesting they should be. The real standard of care is that the therapy is inconsistent. And there's as I showed you, a big disconnect between the recommended therapy guidelines and what's actually provided. And I'm going to show you more evidence for that. And what it seems to be the case, and this is my own opinion, that therapy for acute patients who are less than 1 month or up to 4 months is a bit more structured and systematic, and I'll show you why I think that. But after that, it's mostly counseling for patients and caregivers. There's really less structured therapy that's going on, and it's less systematic. So here comes a study that just came out last year by Palmer et al. And this is a really interesting analysis of the data. This is from their Big Cactus study, where they're looking at a computer-based intervention, but they also had their patients in the control group do usual care. And what they did in this fairly large study, they had 278 patients across 21 national health centers in the UK, and they documented what was usual care. And what they found here was that and this is pretty shocking, so just get ready for this. What they found was that when they documented the usual care these patients were getting, the median therapy over 3 months was 7 sessions. And they were getting a median of 6.3 hours of therapy once every 2 weeks. And so that's what you're looking at here. They're getting about 380 minutes of therapy in 3 months. And then the story gets worse over time. When they actually break it down in terms of time post-stroke, they find that patients who are fairly acute between the 1 to 3 months are at least getting 11.5 median hours of therapy. The ones that are 2 years and 5 years post-stroke are getting 4.5 or 5 or 3 sessions for every 3 months. For the 3 months, not every 3 months. The total therapy time drops from 660 minutes in the first 3 months to about 165 minutes for 3 months in the really chronic patients who are 5 years post-stroke. The time of therapy drops and the frequency drops as well. So patients who are getting at least therapy once a week, almost once a week therapy in the acute phase, are now getting it once every few weeks. And this is usual care in what I think is a really, really large study that was conducted in the UK. And so the median amount of therapy is really subtherapeutic based on everything we've been talking about so far. And it does not match in terms of dosage or intensity based on what we just looked at so far. And actually, the situation in the US is not that different. We just don't have such good data. But when you look at the progression from patients from the acute care to inpatient to home health to outpatient, the intensity and dosage of outpatient and home health is rarely consistent with best practice. As I said, we don't have hard data, but Nina Simmons-Mackey did a survey of speech therapists working in outpatient rehab in 2016 and reported that the most frequent amount of time was 1 to 2 hours of therapy that was happening. And then when you look at the ASHA National Outcomes Measurement, this is the same database that I mentioned before, but now you can start looking at how much time is being spent. The red bars here are patients in the acute phase. So this is the length of stays. The first is about 8 days. So this is right in that acute phase of rehab. Right in the acute phase, right after their stroke or brain injury. You can see that patients are getting about 30% are getting about 3 times a week, 20% are getting about 5 times a week. When you look at patients in that inpatient stage, which is now the average length of stay is about 19 days, so they're still inpatient right after the stroke. They're actually getting fairly frequent therapy. So 50% of patients are getting at least getting therapy 5 times a day. So I think that's great. When you look at the outpatient stage, where the length of stay is 72 days, so this is an average of 72 days after your stroke. It's not even 100 days after their stroke. The frequency of therapy is dropping. Most of the patients are getting between 1 and 2 therapy sessions a week. But I don't know about you, but I was shocked to see this data. 100 days is not even the end of spontaneous recovery. It's just less than 3 months after the stroke, and the frequency of therapy is already dropping to 1 to 2 times a week here. So the bulk of the patients are getting about 1 or twice therapy a week, and then we don't have data on the really long-term chronic patients, but I can't imagine it looks better than this. And I want to sort of bring back what I said about the Cochrane review, right? So this is what all I presented up till now is what's actually happening. And what is the guideline is that actually you need much more therapy. You need therapy for 4 to 15 hours a week. The dosage can go all the way up to 208 hours. That was the Cherney study. And it needs to happen over a long period of time. And this is completely inconsistent with what's actually happening in reality, as well as in terms of the studies that have tried to attempt this as well. So I think that this is a problem that needs a lot of different solutions. Of course, we need to change healthcare and a whole host of things associated with access to healthcare. But one thing that can help here is that a lot of these patients have trouble physically going to a hospital or a clinic to get their therapy. And more things that we do are done on our phone and our computer, and we can use technology to optimize the therapy as well. I will just start off by showing a paper that we published about 2 years now ago, where we did a fairly systematic review. Well, it was a qualitative review of studies that have used technology-based rehabilitation approaches. So we looked at different types of software, different types of therapy, video conferencing approaches, and software that was specific to a specific domain, like naming, and more broad kinds of software. And we try to look at what might be factors that were playing into outcomes. And I won't get into the study in detail because it's freely accessible on Frontiers, but we did look at whether the therapy was tailored to the patient and whether they were varying intensity. And that's actually what was one of the interesting findings of this review, was that because the computer could deliver therapy as and when needed to the patient, they were able to vary the intensity. So some patients got more practice and other patients got less practice. So it seems to be one variable that you can actually manipulate in the context of a computer-based treatment. And this is actually something that studies are looking at more and more, is whether patients can tolerate this sort of treatment. So I don't know if you're aware of this work that came out in 2016. This was done in Canada. It's called the Recover Now study, and they were looking at inpatients in the hospital who all had communication deficits in speech, language, or cognitive communication. The mean length of stay was 19 days, and the median time with the tablet was 10 days. And they were trying to see if they could provide patients with this tablet therapy option, if it was feasible, and whether the patients would actually take to this therapy that early in their stroke recovery. And what they found was that all they asked was patients to practice 1 hour per day. That was what they asked the patients to do. And what they found was that about 83% of them were on average able to complete that recommended 1 hour of therapy. So this is in the acute phase, and these patients are able to practice 1 hour of therapy. The average time spent was about 149 minutes per day. And as you can see in this graph, there are clearly patients who are practicing a lot more than just the 1 hour a day. The graph here is showing you the average minutes per day, and there are patients who can practice a lot more than that, 300, 360, and so forth. And this was really during the time that they were sitting in the hospital and waiting for their next appointment. And so the things that they identify, they point out in this paper, is that some patients actually practice greater than 5 hours a day on the iPad, and these are older individuals who are 55 and 61 years old, and they have some knowledge of the iPad, but they're able to tolerate it. Some patients, as you can see in the individual graphs, practice less than an hour a day. These are the range is a little older, and the reason that they can't do it is because of fatigue, cognitive impairment, and other sort of things like dysarthria, which these tablets are not yet ready to help diagnose or intervene yet with. So there's variability, but overall the study does show the positive, the promise for using tablet-based therapy in the acute care and providing them access to much more therapy time. What they say in the paper is the patients spend over 50% of their time resting in bed and 60% of their time alone, and this time can be used to provide targeted rehabilitation using any type of platform technology. And that can be done by themselves, so they don't need the clinician to be sitting in front of them all the time. So this paper actually came out in PLOS One in 2016. It's a free paper, and I'd encourage people to look at it because it's really well done. A study that we had done several years ago now looked at constant therapy, which is also a tablet-based therapy, and it looked at 51 patients. The control patients only got in-clinic therapy once a week, and they were practicing constant therapy then, and the experimental group got the in-clinic visit once a week, but then they could practice as much therapy as they wanted to at home. So they got that extra practice at home. And you can see on the figure on the right-hand side, the control group got an average of 40 minutes, because when they came into the session to the clinic, by the time they started the therapy to the time they finished the therapy, the program would clock 40 minutes of therapy. The experimental group was getting exactly the therapy, that amount of therapy in the clinic. But in addition to that, they were getting an average of 4 hours at home. All that extra time was at home that the patients who were getting the weekly tests were not, weekly therapy were not getting. And of course, we found that these patients who practiced more therapy at home showed significant positive changes on the standardized test, whereas the control patients didn't show the same level of gains. And then here's another paper by Jackie Curlin that just came out last year. And in this study, they designed a much more tailored treatment for individual patients using an iPad. They had 21 participants. And after they were discharged from an intensive program, they completed a 6-month home-based program. And here it was, again, unsupervised, because all they were getting was weekly teleconference check-ins that they were actually doing the therapy. And on the right-hand side, what you see is a figure from their paper that shows that the percentage of weeks in practice actually correlates with the change in their trained and untrained. They had set up the therapy in that way for their patients. So the more practice time they get, the more gains they show on these specific scores that they're being tracked on. So these are all evidence. These are all beginning pieces of evidence showing that you can actually do therapy at home. You can do it independently, and the more time you spend doing that therapy, you start to show gains. The only difference between these studies and the ones that I was talking about earlier in the presentation are these are all being done at home using technology as the delivery mechanism for the treatment. And then the last piece I want to touch on before I'd love to take questions from you is that because constant therapy has access to a large data set, because the patients are performing therapy within the software platform, we are able to look at these sort of questions in much more detail. So in a recent analysis of retrospective data, we looked at 1,185 patients who either had an aphasia or a stroke with language deficits. The average age is 64 years here. There's about 716 patients who are in the acute stage, less than 6 months, and about 469 in the chronic stage. And the program, the way the data was analyzed for this analysis is that they're looking at progression in a specific domain. So how much change does a patient show when they start working on written lexical decision and they progress along this domain? And there are about 8 or more, no, actually there are 14 domains. There's naming, there's sentence production, there's reading, and so forth. I won't get into all those details. But what you see in this graph is the change in domain score. So in any domain, this first graph is essentially collapsing change in domain across all domains. And it's saying how much overall change in domain score do you see? And this, the x-axis here is showing how many weeks of practice. So the data sort of culled to 10 weeks of practice. And each of these lines is looking at how many days per week are patients practicing. So there's about 609 patients practicing 1 day a week, 759 practicing 2 days a week, 3 days a week. And then by the time you get to 5 days a week, it's 150 patients. But what you can see here pretty clearly is that more practice in that 10-week period results in greater change on this domain score. So they're progressing more in that specific domain. Sorry, I think oh yeah, there we go. They're progressing more in that domain than when they practice less. And when you look at the actual number of items that patients are practicing, again, there's generally improvements over time, but the patients who are practicing less than 5 items a day, they're not getting as much practice, don't show as much improvements compared to the ones that are practicing 5 to 10 items a day, 11 to 20, and 20 and higher items per day. So individuals who are practicing fewer items are not showing as much gains. Individuals who are not practicing as often are not showing as much gains as the ones who are doing the opposite. Again, this is just work in progress, but it starts to show how we can start looking at some of these. Assuming that we can titrate the amount of intensity patients get, we can start looking at this. So I want to stop here and take questions because I did start off with some critical points, but I think right now there's no consensus on what is the optimal intensity and dosage. There's lots of different ways to measure intensity. It is true that the more recent studies that have large sample sizes have found intense aphasia therapy to be feasible, as well as that you don't have to do all the therapy in the clinic. You can supplement that therapy with computer and group therapy settings, and that's the Brittenstein paper I talked about before. And this is where I think there's some room for growth, where when you look at these sort of digital therapies, tablet-based therapies, they provide the opportunity for higher therapy dosage because patients have access to that iPad or computer or whatever that is that sort of adds to their inpatient therapy opportunities. So that's one avenue for working on higher therapy gains. So I'm going to stop here, and I'd love to hear people's comments and questions about this field and about my talk in general. Thank you.
Thank you, Dr. Kiran. That was great. I just want to open the floor now for questions. You can also type in your questions in the chat box.
Okay, thank you, Stacy. And I'm happy. I think the session is being recorded, so I'm happy to share my slides as well. But I think the session will also have the slides as I'm walking through them, correct?
Yes, thank you.
Correct.
Okay, I see some comments about how grateful people are for a very interesting talk.
Thank you.
Hi, can you hear me? This is Julie Schwartberger.
Yeah,
I can hear you.
Hi, thank you so much. This is brilliant. And so my background is physical therapy, and I was surprised and delighted at how closely related the dosage and intensity data for aphasia is with physical function in more of the PT domain. So I feel very bolstered in our shared mission of working on intensity and dosage and getting policy and practice to change. I had a specific question. You mentioned people that practice no more than 5 items per day. I just wanted you to clarify items. So is that like they just did 5 problem questions, or is it 5 domains within that system?
That's a great question. So 5 items is the equivalent of a repetition of a practice. So they did 5 names of pictures, 5 sentences, or 5 words to read, or so forth. Yeah. Did that answer the question?
Yeah. Yes, thank you.
Yeah.
And actually, I want to say that I got the idea for the content of this presentation after I went to a keynote by a physical therapy researcher at a different conference, and he was sort of walking through the same logic that we've got to really look at what we mean by intensity. And he was and his final piece was, we're not doing intense enough therapy. And I thought, oh my gosh, that's kind of what we think is happening in aphasia therapy as well. So I'm glad you found the parallel as well.
Yes, thank you. Very definitely. So this is Julie. I have one other question, if I may. The question is, do you have any recommendations, or do you in your practice or with practitioners you work closely with have a way that you educate and empower your patients and the family members to increase their dosage and intensity?
I think that's right now there's no consensus on how to advocate to the patients. I think individual places, hospital settings, research settings do it differently. I do think that One thing that should be brought up with to every patient is to ask them if they have access an iPad or a computer, because there's so many online therapy resources that they could be doing. There's Lingraphic on the computer. There's so many different options. So if they have access to something like that and they have the resources, and to get access to technology, then I would advocate that they should try that out. And that doesn't mean they're going to stop what they're doing. That just means they're going to add to whatever they're doing. I do think we need to start there, but right now there's no consensus on what that amount, frequency, or any of that is. I think we still have to agree on what we think patients should be practicing at home.
Okay, that's great. I think the subject is very relevant, definitely, in the field of rehabilitation medicine as we move forward, talk about intensity and appropriateness and frequency and all of that, and standardization of practice. We definitely have our work cut out for us. Are there any other comments? I see Michelle, do you have any other comments to add, or Mark, probably, if you're still on the call?
No, I just want to thank Swathi. Thank you so much for doing this on behalf of the Aphasia Task Force, and it was so informative. I really appreciate it. It was wonderful.
Glad to hear that. Yeah. Yeah, this one from Ethan. Okay. How can you ensure if the patient is working at the appropriate difficulty level? Are you talking, so I get the question you're asking is if they're doing the therapy at home, how do you know whether they're doing it at the right level? Is that correct? Before I answer that? Yeah, okay. Yeah, I think that's where the clinician's role is really important. I think that in most of these software programs, there's a way to assign where the clinician is sort of tailoring the treatment for the patient. That's been, that's in concept therapy, that's true in Tactus and so forth. They're all similar in that way. The only way to ensure that they're doing that is to look at the data and check for accuracy and if possible, latency, stability. There's no other way to really check for that. I mean, in the case of constant therapy, the program does progress you, and it's based on the same logic I just said, as long as there's some stability in performance and there's clear change in performance. But to be completely automated, I think will take a lot more data checks that way. Is that the question you're asking me? I'm not sure if I answered it too specifically. Maybe you're looking for something broader than that. I don't see a response, but I think the reason I'm hedging so much is because there's this other notion of intensity doing therapy that's actually hard is more intense. So we don't yet know how all that plays into this just prescription of intensity. Oh yeah, okay. I'll get to that question in a second. I just want to finish the other part where the other work that I've done in terms of complexity of treatment suggests that maybe you don't need to give the easiest therapy for the patients all the time. You let them you let them struggle a little bit in what they're doing, and that may be beneficial in terms of gains that you see in transfer and so forth. So how that plays into intense therapy, it's not clear yet, and so those are the things that need to be ironed out. So that's why I was giving that broader answer. But your second question is, how do patients and families know what to select when there's so many options that are out there? It is, I think so many options out there is a good thing. And of course, it's a confusing thing for patients and family. But I think that the fact that there are so many options should encourage patients to try something out. So I don't know if people are familiar with the Aphasia software finder. This is a software by the Travis Talk Foundation, and they just, they have a whole range of software that people can look up for their specific deficits. So there's a way to narrow down the choices of patients, and actually that's meant for patients and caregivers to go to this website and identify the kind of therapy that would work for them based on the deficit, that kind of therapy program that would work for them based on the deficit that they have. I think it's a start. I think that what's happened so long is that there's absolutely no choice for the family and for the patient. They've been such passive recipients of the therapy, and if they can make it to therapy and they get therapy, it's great. If they don't, sorry, bad luck. And that was what I was showing you from the NHS data that Rebecca Palmer published. I think that's going to have to change, and programs like this website, like this Aphasia Software Finder, is one start where patients can actually narrow their choices down a bit more. Okay, there's another question. I think as we move forward to investigating the impact of intensity, we really need to pair our analyses with the consideration of the salience in the kind of treatment being delivered. I completely agree. I think that, yes, I think that that's why I was presenting intensity in the context of those 10 principles of neuroplasticity, because these things don't really exist in isolation. And there's no one thing that is going to be the panacea for treatment. What is not well known, but I suspect is absolutely true, that fewer repetitions of a very salient type of treatment will be more beneficial than many repetitions of something that's not salient for the patient. I mean, that's just my instinctive answer, but I would imagine that would, yeah, you agree too. I think that would be something that we would need to show systematically. There's work back in the 80s and 90s that Bob Marshall did about having patients pick items that were salient for them. I think we have to do that a lot more. And I will just say that the Curlin paper that I presented started to do some of that. They did try to pick items that were relevant for their patients. And so that we can start looking at those kinds of things. The other thing about software programs is that you can just take out one set of stimuli and dump a new set. And those stimuli that the patient works on could be really tailored to the patient. It could be their own family pictures and their life story. So we can start to make it more and more salient for the patient that way.
Okay, I think we have to wrap up as the hour comes to a close. Thank you so much, Dr. Kiran, for sharing your expertise with us. And we'd like to make a shameless plug for our next virtual happy hour, which is March 24th. More details will be forthcoming on that. But once again, thank you very much for joining us this evening, and hope to see you all soon.
Yeah, thank you very much. And feel free to email me if you have other questions or comments. But thanks for your time and listening.
Thank you.
Thank you.
Thank you.
Bye.